Welcome back to Dysphagia Matters. Today's episode is all about evidence, and more specifically, how we make sense of the evidence we're presented with as dysphagia clinicians.
We're focusing on meta-analyses, which many of us encounter regularly in the literature, but may not always feel fully confident interpreting or evaluating. So to guide us through this, we're joined by Professor Kendrea Garand from the University of Pittsburgh in the US.
We'll break down what the meta-analysis actually is, why it can be such a powerful tool for clinicians, and why it's not always enough to simply trust the conclusions.
Kendrea walks us through how a meta-analysis is conducted, what goes into pooling data, and where things can get tricky, especially in dysphagia research, where patient populations and interventions can vary so widely.
For busy clinicians, we'll highlight a few essential appraisal questions you can ask yourself in just a couple of minutes to decide whether meta-analysis is trustworthy and relevant to your practice. Finally, we'll discuss how to balance evidence from meta-analyses with clinical expertise and patient values.
So let's dive in.
Welcome to the Dysphagia Matters podcast, Kendrea, and thanks so much for joining us to talk about a very important but also complex topic, meta-analyses.
Yes, thank you so much for the invitation. I'm really excited to be here with you all.
So in this episode, we would like to discuss with you an article that you and your team published. Its title is How to Interpret and Evaluate a Meta-Analysis in the Field of Speech and Language Therapy, a tutorial for clinicians. Before we jump in, could you tell us briefly what motivated you and your team to write this tutorial?
Yes, when we were thinking about the level of evidence hierarchy, meta-analysis is typically at that top of that pyramid, representing the highest level of research evidence, because its strengths really lie in the fact that you're actually synthesizing information from across multiple studies in order to answer the critical questions that we all have as clinicians about the clinical services that we provide, such as, treatment effectiveness. So essentially, then that meta-analysis is bridging that gap between research and clinical practice, and allowing us as the clinicians to really confidently integrate the best available evidence, right, into our own clinical decision-making that we do every day. And I would say that a lot of us as speech language pathologists have rarely, if any, have received any training in how to really interpret or critically evaluate meta-analyses. And so, in America, we have ASHA as our, obviously our accrediting organizing body, and they require basic research design and methods coursework as part of the graduate curriculum, but that may or may not cover meta-analytic methods, or at least do so efficiently. And my disclaimer already is that I am not a statistician, I'm not an epidemiologist, I'm not a public health scientist, but I am a consumer of research, right? And I also participate in conducting research. So my co-authors, so shout outs to Dr. Donahue and Dr. Carnaby, we felt that this type of work would help contribute to fill in that problematic gap that we currently have, right? So clinicians were expected to provide this evidence-based care, but may lack the necessary skills in order how to really critically appraise the very studies that we want to help guide our clinical decision making. And again, that's through no fault of our own. And so without these skills, we may have errors, right? So we may increase the risk of accepting flawed conclusions, or we may dismiss, valuable evidence that could then help better improve our patient outcomes. And the meta-analyses published in CSD, right, so Communication Science and Disorders field, they do have inconsistent reporting and they do have quality issues, and there's evidence to support that as well. So tutorials like ours, we hope that that's the purpose behind it, can help empower clinicians, right, to allow them to become better informed consumers, allowing them to distinguish these kind of well-conducted studies from those that are flawed. We also hope that this work was also a call out to the journals that are publishing these types of works call out to the researchers performing studies, conducting studies, for them to be transparent in their methods, for them to be consistent with how they're reporting those results. So then that we as the informed consumer then can judge sufficiently the quality of that study. And then, have that final question of like, do I change my clinical practice in response to that?
Yeah, thank you. And like you said, so none of us is a statistician or a methodologist or anything. We just learned it if we were lucky in our studies or maybe beyond that. But I think that makes our field so interesting, but also so complex because we need to know so much more than only dysphagia or only swallowing, quote unquote. So for those who are unfamiliar with meta-analyses, could you maybe give a definition or explain what they are and why they can be so helpful for especially us as dysphagia clinicians?
A meta-analysis is a particular research method, and its power lies in that it is systematically combining and statistically analyzing results, not just from one study, from multiple independent studies on, a very similar topic. And so then rather relying only on a single study's findings that may have its own limitations, that may be a small sample size, et cetera, that meta-analysis pulls that data from all those studies together in order to really provide a more comprehensive and therefore more reliable answer to the clinical questions that we have. So, you yourself, like I know I have, I'm sure we've all encountered situations where there's, we see these different studies, but they have like slightly different conclusions, right? Even if it's about like, say, the same intervention. And so meta-analyses can really help resolve those contradictions by identifying the patterns that are across those research studies, and really allowing us to understand better where those differences are coming from, right? From the patient population studied, the treatment intensity provided, or just the quality of the study overall. And so then those meta-analyses overcome those limitations from just that are inherent in only having a single study. So it's combining those participants. It's allowing for more statistical power, and it helps kind of increase just our confidence in the results that we're then reading. And so that's going to help you determine, as a swallowing clinician, interventions like, e-stim or using a chin tuck or modifying textures. If those kind of interventions that we're providing truly improve the outcomes for our patients. And so we can think about it this way. So if you have, say, 5 different studies, right? And so they're all examining this very particular swallowing therapy. Each individual study may have different sample sizes, maybe slightly different protocols, intensity or other dosage parameters. So they have slightly different results. Again, a meta-analysis is going to bring all that together, and it's going to weigh those findings based on the quality of those studies. It's going to consider things like participant size, allowing then this kind of overall effect calculation to occur. So you as the consumer then, right, as a reader, that meta-analysis is going to give you a much clearer picture of, oh my, this is actually work. Again, is this something that I should be employing in my own clinical practice? And if you think about, the 3 pillars of evidence-based practice, one of those pillars is about that best available evidence. And so if we're truly understanding the power behind that, that better allows us to kind of transform us as a clinician from someone who's just like, oh, I'm blindly following because I knew my clinical supervisor did it this way, right? Really allowing us to engage in that critical thinking skills and using those skills. This is not like riding a bike. We have constantly have to use our appraisal skills. And so then we can evaluate whether the guidelines that we're promoting, that we're thinking about, this should be on solid evidence. And that's what's going to help contribute to better outcomes for our patients.
Yes, absolutely. And I just realized maybe we should differentiate the meta-analysis from a systematic review because, like you said, in meta-analysis, we look at multiple studies on the same intervention for same population. But how does this differ then from a systematic review?
So the beginning processes are definitely going to be part of the same. And then once you start getting down, it's really about the statistical analyses, right? That's what brings in that meta part versus, say, from a scoping review or a systematic review. I like to think of it kind of like on a continuum. scoping review, just kind of seeing what's out there. Systematic review, you have a solid question that you're trying to answer and you're trying to synthesize information from the articles that reach whatever eligibility criteria you have. But then that meta-analysis part, so continuing on down the continuum, that is that statistical analysis. That is where you are truly quantifying, again, that kind of pooled effect, in addition to just examining quality like you would find in a systematic review. So it's really just taking that into that next level. So how the data is presented even visually is going to be different from a meta-analysis versus a systematic review. And there are some times where the authors, and I've had to do this a couple of times in some of my systematic reviews that we publish out of my lab, because we have this good hearted faith of like, we're going to do a meta-analysis on this topic. But then we dive in, we get our articles, we're reviewing them, and they're like, we can't pull them. They're too heterogeneous for us to actually perform these analysis that we would normally do as part of as a meta-analysis. And so then we would just have to publish it as a systematic review.
Yeah, and we'll talk about this in more detail and hopefully make it as easy to understand as possible. So if I want to know which treatment works best for the patients in my clinical practice, I ideally find the answer in the results and discussion section of the meta-analysis. So someone has done the work for me and checked the evidence and has pooled all this data together. But why is it still important for me to know how to interpret and evaluate a meta-analysis rather than just simply trusting the results of this paper?
I mean, the biggest thing is just because something's published doesn't mean that it's good. And you can say that about,
yeah.
Right. And you can say that about anything, right? In the rise of social media. And we do talk about this because this, again, was one of the important points that we were considering of like, do we, because I mean, this took time just to write this tutorial. We commented that there are ongoing concerns about the inconsistent reporting, about the quality of the studies in our journals. And just because, in that title, it might say a meta-analysis, that's not this automatic idea then for the consumer to be like, oh, well, then it has to be trustworthy. Meta-analysis can suffer from significant methodological flaws, just like individual studies can. They may include really poorly designed studies that shouldn't have been included. They may use inappropriate statistical methods. There's different things that are calculated as a meta-analyses, and some of those have different calculations depending upon these decisions that have to be made. Or the authors themselves were kind of like what we would call like cherry picking, like what studies that they wanted to include, but while ignoring other ones. And so there's biases that can still be present in a meta-analysis. So, I mean, really put simply, a meta-analysis is only as good as the studies that it's going to include. So if researchers are trying to pull together studies that are weak, that have this high bias, then that combined result doesn't automatically magically make it stronger evidence, right? It's still unreliable. And so then you as a reader then will still need to assess the quality of those studies that were included. Were they appropriately selected? Were they of sufficient quality to even be included? In other words, you're answering like, should these studies have been combined to begin with? And you'll need to consider then on whether or not it influences your clinical practice of like, does this apply to the patients that I see? You'll need to determine whether those study populations or the patient severity kind of match your caseload, that patient that's sitting in front of you, and whether the interventions are even feasible within your setting. Some require devices that are thousands of dollars. Whether the outcomes that they're reporting align with what matters to your patients. A meta-analysis showing, say, statistical significance, right? That arbitrary p-value of less than 0.05, okay? That doesn't always translate immediately into clinical significance for your practice. We know we have scarce resources. That's not only in, say, Germany, not only in America, that's worldwide. I mean, I don't think any of us want to implement an intervention or assessment that's ineffective, potentially be harmful to the patient. And so we want to make sure that, again, we're that informed consumer of the evidence, not that passive, just recipient, just tell me what to do. And so by being informed, we can then increase our own clinical confidence, and also through our shared decision-making of telling that patient, this is what we know. This is what the evidence is demonstrating to us. And then really allowing that process to really help inform then those care decisions that have to be made.
So you've mentioned already some, yeah, let's call them red flags within the studies that we include in our meta-analysis. I guess especially in dysphagia research where populations and interventions both can vary greatly, what are some of these red flags that pooling studies might be appropriate?
I would say probably when I'm kind of reviewing a meta-analysis, I mean, the first thing I'm kind of looking at is like, what was their question, right? So, what was the patient populations of interest for them? And are they different across the studies? Pooling studies that have a head and neck cancer population with patients, say, with a progressive neurological disease, that's vastly different, right? The mechanisms of the dysphagia may be different. The treatment options available may be drastically different. In addition to the interventions, right? Are you comparing more than one intervention? Is one study combining that diet modification alongside ESIM, and then the other one's doing like a postural maneuver, right? Combining all those would probably make little sense. Again, those interventions are, working through different mechanisms in order to treat the impairment. And even if it is the same intervention, right? Each study was examining the same intervention, the implementation of that intervention truly matters. So another red flag would then be to actually look at the treatment protocols and see if they were similar or if they differed. And if how they differed, do you think that actually made a meaningful difference in the outcome? So a study might vary in treatment intensity, right? Twice weekly versus daily, duration, 2 weeks, 4 weeks, 12 weeks, parameters, right? So just go back to ESIM because I think that's easy to think about, like the parameters of ESIM settings. Those are pretty drastically different, and you think that would actually influence outcome, then combining those, or again, ignoring those kind of factors that could then impact the results, right? So it wouldn't make sense then to actually combine them. And also then looking at the outcome measure that we're reporting. So if studies were defining, I'm going to go back to treatment, like treatment success, right? So say one used a penetration aspiration scale, another used, say, some kind of like patient-reported outcome measure. Another one was using, say, pneumonia rates, right, during hospitalization or post-hospitalization. Combining all those statistically wouldn't make sense to us. And also, we want to think about what is it measuring? Because each of those examples I just gave, PAS, patient-reported outcome, pneumonia rates, those are measuring different, potentially aspects of swallowing, so they're not directly comparable. And then also going back to, I forgot to mention this when I was discussing the patient populations, but also the severity level of that, not just the disease or etiology contributing to that dysphagia may be, a symptom of that process, but also the severity of dysphagia. So if you want to think about the spectrum of severity, right, none, mild, all the way up to severe or profound, that can mask important differences between those kind of levels. And so an intervention that says may work for somebody with a more mild, however you're going to define mild, mild dysphagia may be ineffective, potentially harmful for those that have like this kind of severe, profound dysphagia. However you're going to define that. So with that, meta-analysis is not attempting then to like account for those differences, say in severity. Then again, that pooled result may not then specifically apply to the patient population that you're treating. And then lastly, I would say is look at the heterogeneity of the studies included. And a really easy way to look at that is that is one of those things we were talking about, the differences earlier between a systematic review and a meta-analysis, is they should be reporting a heterogeneity statistic. And so I think in our article, we discussed the I-squared statistic. And so if those are very high in values, that suggests high heterogeneity. To you as a consumer, then how you're going to interpret that is then those studies may be too different in order to meaningfully combine. And so that pooled result, even though if you get a number, like it may not actually, shouldn't be trusted, in other words.
So it just doesn't make any sense. So you can still pool those results, but the outcome, the number that we get
wouldn't be meaningful.
Yeah. Okay, great. So let's say the meta-analysis was conducted well and pooling of study results was appropriate and makes sense. What are concepts that I need to understand to interpret the findings of this meta-analysis?
When you're thinking about, so you're getting these results. We already talked about like the heterogeneity statistic, right? And then we can also look at things. One of the things I said is sometimes the differences between easily detected between a systematic review and a meta-analysis is how those results are also being reported, and that includes visually. And so when we're thinking about the forest plot would be a really great visual example of the results of that study, right? Or how we should be interpreting that data. And so that forest plot is going to provide visual information, but also numerical information about not just each individual study, but also that overall pooled effect about whether or not we have increased confidence that there's a true effect actually being reported. In other words, if you're, say, looking at that heterogeneity statistic, you're asking yourself, are these studies similar enough that combining them makes sense? Or are we comparing apples to oranges? The confidence intervals that are shown in a forest plot is telling you, are they all leaning towards the same side, right? All leaning towards that it's supporting the hypothesis that we think it's supporting. Is it supporting, say, going back to treatment? Are all these studies actually supporting that this treatment is effective? And then looking at that pooled effect size. So if we weight these studies, right? And so those studies that have higher quality are going to contribute more to that weighted average than those that are a little bit lower quality, but still eligible to be pulled together. Then we can look at that just visually in addition to just looking at like, what are the numbers saying? But I think kind of going back to that's really that skill that we got to kind of keep practicing and understanding what all these numbers mean. And then even though there's always a discussion section in an article, that's their viewpoint, their interpretation of the data. It's still worth us, and the burden still should remain on us, that don't skip over that results section. Like, don't just go straight to that conclusion paragraph and be like, you tell me what I'm supposed to interpret. It's still your due diligence and actually to go and look at those kinds of things. And those pieces are going to pretty quickly tell you about whether or not this is kind of worthy of you to spend your time reviewing that 20, 30, 40 page meta-analysis in order to help inform your clinical practice.
And I guess not only reading the abstract if the meta-analysis is of interest to you.
Correct.
Yeah, so to make this judgment, your paper lays out very helpful appraisal questions as well. So if a dysphagia clinician had only 2 to 3 minutes to judge whether to trust a meta-analysis, what top questions should they ask? What do you think?
I would, going back to the prior question about red flags, I would kind of go through and ask myself internally, like, are any of those kind of red flags present? You know, different patient populations, different treatment protocols, you know, and what is the actual magnitude effect, right? Looking beyond that p-value, if you will. We talked about the forest plot on this last question. So really thinking about that visual display. So for the studies that were included, what do those results look like? Are those lines, like in the confidence intervals, are they pointing in that same direction, kind of supporting what we would want? Or are they all scattered over, some really wide, and that's what we don't want. We like our more narrow confidence intervals. Or are they going in different directions, right? So some are showing benefits, some are showing ineffectiveness or harm. Because if they are that wildly inconsistent, then pulling them again is questionable. That even reduces further my confidence and that this meta-analysis should have even been performed. And that would be regardless of like what the overall statistic would be. You know, check how many studies were included in that forest plot, right? Are there only 2 studies? That's not a lot of pool, right? Or is there substantial evidence that we can actually, it makes more sense for us to perform meta-analysis. Look at the funding sources. You know, conflicts of interest. Was it an industry-funded study of their own products? That to me deserves like extra scrutiny on top of what we would consider kind of more typical critical appraisals. You know, pay attention to who's writing it and what their affiliations are with that.
Yeah, it's so important to be critical, maybe not overly critical. We do want to transfer something from research into clinical practice, and we may always find some maybe weaknesses of studies, but it's so important, like what you just outlined, to look at those really important aspects to make sure that it's rigorous research that we can really translate into our clinical practice. And talking about this, how can clinicians balance evidence from a meta-analysis with clinical expertise and patient values? Just because the research says this is working, this is effective, does it actually mean that we should implement it into our clinical practice, especially given the individualized nature of dysphagia management.
Oh, that is very, very true. I mean, even just the description that we discussed in the very beginning is the power of the meta-analysis comes that you're combining, right, studies. And so that means that that is a group level piece of evidence that tells you what kind of works on average across that population or populations. But all of us know that when we're considering our assessment and treatment designs, that it must be inherently individualized. Now, your clinical expertise that you're bringing will still help you kind of determine whether that average patient in the meta-analysis, it resembles like that specific person sitting in front of you. You know, if you want to think about like a meta-analysis, say in a post-stroke dysphagia, that may not apply to your 85-year-old, yes, post-stroke patient, but has multiple other comorbidities, advanced dementia, limited endurance to participate, right? You know, all these other things that need to be considered. And we also recognize that, like, even when evidence may support, say, an intervention, patient preferences are paramount, right? Evidence should not override a patient's autonomy. All of us each probably has a story or two or a dozen or 100 that some of those patients have prioritized, say, their safety, right? And accepted modifications to their diet or accepted, placement of a feeding tube, et cetera. While others have done the opposite, right? They prioritized pleasure of eating, right? And accepted the risks that may come with that. So evidence should inform the conversations, but they shouldn't dictate them. And so your evidence then will help you, your expertise then will help you understand the evidence, but in a much broader context of all the clinical nuances that would never be able to be captured in a meta-analysis. And so that way you can understand those results still within the context of your own clinical environment, the play, if you will, that your patient's bringing to your clinic, your institutional available resources, your patient's support systems, the feasibility of you implementing the treatment, and then all the similar kind of other additional factors that you would likely consider when you're thinking about designing a management plan.
So there's so many different things to consider, and it's, just makes it more clear how complex the work is that dysphagia clinicians actually do. Do you have any specific examples where understanding some of the meta-analytic principles can also change how a clinician interprets popular dysphagia interventions or other emerging technologies?
I think a pretty probably popular example would, and I mentioned this treatment a couple of times now, is the eSTIM literature, so neuromuscular electrical stimulation. Those early studies for eSTIM generated a pretty significant excitement, right? And marketing of that device, and it's being implemented for dysphagia management. And so some of those clinicians, adopted it very widely as almost like the go-to blanket tool. But when meta-analyses started beginning to pull that evidence, they revealed very high heterogeneity, especially in the treatment protocol, right? So where you're placing the electrodes, the simulation parameters, the duration of the session, duration of the treatment program. There was also inconsistency in the outcome measures that they were using to support, kind of success or not. And so even those modest effect sizes, they weren't really supporting this use of like, oh, that's clinically significant for me. So then understanding then these principles that go along with these different design types, including meta-analysis, will help you recognize that like some evidence of effectiveness doesn't always immediately translate into like strong evidence that would justify you with the cost of that treatment, the time invested to implement the treatment, not just on the clinical side, but also on the patient side as well. So a clinician that understands, and we're considering these factors that contribute to heterogeneity and understanding effect sizes, because there are different ways that can be reported. Cohen's D is popular, but there's other ones, might conclude that eSTIM then shows promise, but may lack the robust and consistent evidence, I'll say, that really should be needed for this kind of routine implementation, right? Especially given the expense of it and the upkeep for it. I would say another one, this gets discussed pretty often in not just in the evidence, but also its conversations in social media and blogs and podcasts, would be the implementation of thickened liquids, right? As part of like a diet modification. That's been a cornerstone of dysphagia management for decades. Meta-analyses that really are examining their effectiveness reveals really surprisingly mixed results, even though it is, again, a common cornerstone. So some can show that, it reduced the event of aspiration or the depth of aspiration, but failed to really find true significant impacts on pneumonia rates. So it didn't change those. And that latter one, right, the pneumonia rates, that's a big one, right, when we're considering like patient health. Others highlight obviously significant effects on hydration status, patient satisfaction, both of which are often reported to be as more negative. So understanding then those nuances can prevent you then from just solely defaulting to, say, thickened liquids, for example, without consideration of the evidence that actually supports improved health outcomes versus just these kind of surrogate markers like, identified aspiration on imaging, right? And so automatic thickened liquids. It also highlights the important, I think, another soapbox of like balancing that kind of aspiration reduction with quality of life, but also other health risk. Dehydration would be a good example of that one that we just discussed. And then for me, since my primary clinical work is in patients with progressive neurological disorders. So I'm the clinician in our ALS clinic, and I see a lot of other similar conditions. And so expiratory muscle strength training is another one to bring up then. So our group performed, and Dr. Donahue also led this, we actually did perform a meta-analysis. So we were looking on exercise in ALS. So not just exercise for swallowing in ALS, but like any exercise in ALS. And so that included these studies about using EMST. Now, some work showed some promising effects on swallowing outcomes, but when you looked at our meta-analyses and we're pulling all those studies together, and you're looking at confidence intervals, and you're seeing the influence on sample sizes, the confidence intervals were wider. That indicates then some uncertainty then, or that should introduce some uncertainty about the true effect size then. So a clinician that understands how to appraise a meta-analysis wouldn't then necessarily like dismiss EMST, but would just be more accepting on the evidence is preliminary, like maybe offering now a trial basis with careful monitoring, rather than just kind of like this confident first line recommendation. When we're able to apply these critical thinking skills, that allows for us to prevent premature adoption of something, but also at the same time, unwarranted dismissal of something that actually may be affected. And so I think overall, having this understanding of how to review a meta-analysis, just helps prevent you from being swayed, right? Marketing hype, what's being discussed, the algorithms now. So every ad that you're going through is looking at this device. But also you were talking earlier, but also being too overly rigid, right? And just saying like, well, nothing works, right? And just in how you're interpreting the evidence.
Yeah, sometimes this impression can emerge from the literature that we're reading, but I think you really nicely explained that it's important to use our critical thinking skills while reading those papers, but then also while translating the evidence from the research into our clinical practice. So not stopping once we've read a paper saying, okay, this seems to work in research, so it got to work in my clinical practice, but actually keep on monitoring and checking if it's appropriate for my patient, and then also looking for potential adverse events, because maybe they haven't looked at those negative effects in the research. So yeah, it's all about this critical thinking. Thank you so much, Kendrea. This was really interesting. And for everyone who has maybe some questions or more interest in this topic, we can highly recommend having a look at your paper, and we'll put it in the show notes. Thank you so much.
Yeah, thank you.
Thank you. Bye. Thanks so much for listening. If you enjoyed this episode, leave a review wherever you listen to podcasts. You can connect with us on Instagram, LinkedIn, and Blue Sky, or visit our website, dysphagiamatters.org. We'd love to hear from you. Until next time, take care.